purpose of the surgical checklist is to improve safety, and it does that in two ways really. One is a very simple process method of making sure that basic common sense things are not forgotten. So it is not actually about filling in a form or ticking boxes, it's about going through each of those items, reading them out, and with your brain engaged, checking that they've actually been done.
It helps you make sure that you've actually got the right patient, that you're doing the right operation on them, that you've got the right conditions for that operation, and that nothing should go wrong.
But the second purpose is to make sure that everyone's teamwork starts to be expressed right at the beginning, and people are able to speak up and to recognise that they're part of a team.
It's really any situation where you're doing something that's potentially harmful, which an operation is to the patient, and any situation where the patient would lose contact with you, so that's whenever they're getting anaesthesia or sedation. So the checklist comes in 3 stages. That's the sign-in, time-out and sign-out. And the sign-in is before the patient goes to sleep.
Good morning, Mr. Campbell. My name's Kim. I'm the anaesthetic technician. I'll be helping care for you alongside the anaesthetist today. How are you?
Good, thank you.
Okay. Can I please check your identity bracelet? Can you please tell me your full name and your date of birth?
Robert Lindsay Campbell, 30th of the 10th, 55.
Thank you. And the hospital number is correct. Mr. Campbell, what are we doing for you today? What operation?
Hernia operation.
And what side are we doing?
Left-hand side.
The left-hand side. Okay, I'm just going to check the consent form here. Today we're doing an open mesh repair left inguinal hernia. And is this your signature?
Yes.
Thank you. Has the surgeon marked the correct site?
Yes.
Okay, can I please check? Thank you. Mr. Campbell, do you have any allergies that you're aware of?
Latex.
Latex allergy?
Yep.
Okay.
We're prepared latex-free theatre.
Thank you, Ellie. Mr. Campbell, I'm just going to check with the anaesthetist and the surgical team that everything else is ready.
Okay.
Dr. Singh, are you happy that all safety checks are completed with the anaesthetic machine and the equipment we're going to use?
Yes, there's no concerns.
Okay, and are you anticipating a difficult airway?
No.
Dr. Perry, what is the expected blood loss?
Minimal. Dr. Perry, do we require any special equipment today?
We're going to use a suture-free mesh.
Cool, we have that ready for you in theatre.
Great. We're ready to go?
All ready?
Okay, Mr. Campbell, we're ready to go.
So the checklist is extremely powerful, yet it's a very quick intervention. So one of the things it does is it makes the most of these natural pause points in the flow. So it's not at all disruptive. And if run really well, the whole thing can be done in less than 2 minutes.
And there's a thought that in fact doing the checklist may slow down the list. In fact, that's been proven not to happen. It's actually been shown that it speeds it up because it enables you to find out about things that you need to plan for.
It's a tool to promote communication, to get people to know each other's names and to get used to speaking, so that if something does go wrong, they're more likely to speak up and say, hang on a moment, is that correct? That process of speaking once is thought to activate people. Once you've spoken once, you're much more likely to speak again, particularly if that process is done in a positive and encouraging way that makes you feel that you will be listened to.
And we would expect anyone that's in the operating theatre, from the most junior staff nurse, a medical student or an anaesthetic tech, to be able to ask what for them may seem like a dumb question but actually may be a very important question.
The second phase is after the patient's asleep, usually just before the incision, if you like, the last point at which one could reasonably stop and reconsider.
And that's as close as possible to starting the operation, checking that we really have got the correct operation. So that's a time when we just do a quick round to make sure that everyone knows who they are, so introduce themselves by name so that they're part of the team. Now, it's quite important that you choose a time when in fact people can stop and listen to it.
The surgeon and the assistant and the anaesthetist and those people that might otherwise be doing things are actually not doing them at the moment, but concentrating and answering and considering the checklist appropriately. If we're using the pieces of paper that currently are in place in most hospitals in New Zealand, the circulating nurse could be the person that does it, or the anaesthetist, or somebody that's not obviously scrubbed in the operative field. Probably best not the surgeon unless the list is physically up somewhere where he can see it, like on a whiteboard in the operating room.
For me, one of the most exciting things about the checklist is its ability to be able to bring the team together and really improve the communication in theatre.
It just ensures that every member of the team is present, and it also ensures that we do all know each other. We often do have different people coming into the theatre room.
I think it makes everyone stop before the case, at the end of the case, everyone stops and talks about things together instead of everything just being disjointed, so it helps that communication as a whole team.
And the introductions at the very start of our time out achieves that. Everyone has the opportunity to speak.
You feel like you're part of the team, if everyone knows your name.
We're all human, so we are prone to making mistakes. Doesn't matter how many years of training that you've had or what level of experience that you've had. We are prone to we can make mistakes, and this is one way, this checklist is one way of decreasing that risk.
Can we run time out, please? I'm Mr. Kumar, the consultant surgeon.
I'm Will Perry, the surgical registrar.
I'm Hannah Witham, scrub nurse.
I'm Vic Singh, the anaesthetist.
I'm Kim Draper, anaesthetic technician.
Rachel Sturgis, circulating nurse.
And I'm Ali Aikenhead, circulating nurse. Do we all agree here that we have Mr. Robert Campbell here for an open mesh repair of a left inguinal hernia?
Yes.
Yes.
Surgeons, do you have any concerns for this patient?
No, we're going to take about 30 minutes and going to use the suture-free mesh.
Great. Anything from the anaesthetic team?
Mr. Campbell has a latex allergy, but all precautions has been taken. There's no other concerns.
Great, thanks. Scrub nurse, can we confirm our sterility?
Yes, our sterility is confirmed and we have no equipment problems.
Great, thanks. Have we given antibiotics?
Cafazolin IV has been given.
And is there any thromboprophylaxis required?
Mr. Campbell has TED stockings on, but he does not require any other thromboprophylaxis.
Thanks. And surgeons, do you require any imaging to be displayed?
No, thank you.
Great, ready to go.
And the third stage is at the very end of the procedure, and that phase is focused on the things that are important to hand on to the staff who will continue looking for the patient after the operation's over.
It's before the surgeon leaves the theatre, which they sometimes do before the patient wakes up, when everyone's available and everyone should take part in it and everyone should be able to safely pause to do so.
Can we run the sign out, please?
Yes, can we confirm that on Robert Campbell we've done an open mesh repair of a left inguinal hernia?
Yes.
Thank you.
Yeah. Is our count correct?
The count is correct.
Have we had any equipment issues?
No equipment issues.
Thanks. Surgical team, do you have any post-operative concerns for this patient?
No, we'll see him before discharge today.
Great. And from the anaesthetic side, anything from you?
No concerns, but latex precautions should carry on in recovery.
Thank you, they're aware of that too. Cool.
All right, thanks.
Guys.
Thank you.
The checklist has been assessed in 3 major studies, and in each of those studies there's been a dramatic reduction in patient harm, both mortality and morbidity. The primary study, which involved 8 sites around the world, of which Auckland was one, showed approximately a 30% reduction in deaths and in major harm.
I think once you look at all the incident reports, you can see times when maybe the blood wasn't ordered that should have been ordered, the antibiotics were given late, there was some hesitation about the actual operation. Adhering to the checklist enables us to sort those things out at an appropriate time. There's a variety of reasons why people resist using the checklist. I think first of all there's the issue of change.
But I think if you can show them the benefits of it, people will quickly come around to the idea as well. And if it's done properly, it works very well. And the whole idea of doing no harm to your patient is extremely important.
The health service, we've been subjected to a lot of changes and a lot of theories about how we can improve care. And doctors are known for being sceptical at the best of times.
And after years of work, somebody arrives and says, here's a good idea, use a checklist. And that's a big difference. And you think, I'm too busy, who dreamed this up anyway? And so a bit of resistance is understandable. But if you look at the process by which it was developed, which was very consultative, and then the subsequent research which established its use, I think we have to get over that and actually understand that this is an important tool and adopt it. And I think the people coming up from the bottom will adopt it much more readily.
Gone are the days where you do your own thing and the other person does their own thing. We're all in it together, and the sole purpose is patient care.
What I like is working in a team that works well. I like working with a surgeon, with theatre staff, with anaesthesia technicians who all talk with each other, we get on well, we plan what we're going to do, and then the day proceeds as planned so we can give the best care to our patient.